We announced that this is a session that is oriented about the guidelines, the second session about guidelines, new guidelines from the ESC 2022. We start with Dr. Ahmed Hassan from Cairo University, who's going to present a talk about the 2022 ESC guidelines on pulmonary hypertension.
Good afternoon. First of all, it's my honor to share in this important scientific meeting. وبشكر أستاذي أستاذ الدكتور مجدي عبد الحميد للدعوة. My task today is to talk about the new guidelines on pulmonary hypertension. In fact, it's a large, extensive guideline, so I will try to focus as possible on the most important point. Pulmonary hypertension is a heterogeneous pathophysiological condition with a complex management that need a multidisciplinary approach, and the overall prevalence of all types of pulmonary hypertension represent 1% of global population. And the new things in our new guidelines is new changes for the definition, the hemodynamic definition, some modification of the classification, and expansion of the risk stratifications and simplification of follow-up, and some modification of the treatment algorithm. And if you looked at the new hemodynamic definitions of pulmonary hypertension, the majority of population had a mean pulmonary pressure of around 14. And if we looked at the two standard deviation above it, it will be 20. So the guidelines adopted a new definition. Instead of 25, it become any patients with mean pulmonary pressure exceeding 20 millimeter mercury by right heart cath is considered to have pulmonary hypertension. And we have then the precapillary and post-capillary and the combined form. The precapillary is now has the value of pulmonary vascular resistance incorporated in the definition. So the patient need to have mean pulmonary pressure of more than 20, with wedge pressure of less than 15, and pulmonary vascular resistance that exceed 2 Wood units. In fact, the pulmonary wedge pressure in normal population is 12 or less. However, the 15 is arbitrary, and it used all في literature كله. بالتالي all the classification and the trials included patient with 15 or less, and this has been adopted again in the recent guidelines. Patient with isolated post-capillary hypertension has a mean pressure of more than 20, pulmonary wedge pressure of more than 15, and pulmonary vascular resistance of 2 or less. The combined post and the pre, we have mean pulmonary pressure of 20, the mean wedge, the pulmonary arterial wedge pressure of more than 15, but the pulmonary vascular resistance exceeding 2. There is the exercise pulmonary hypertension or exercise-induced pulmonary hypertension has been clarified more in the recent guidelines. However, there is no enough data on how to manage and how to follow patients with exercise-induced pulmonary hypertension, and diagnosis is mainly based on looking at the behavior of of the pulmonary artery pressure with the changes in cardiac output slope. The steeper the increase in mean pulmonary pressure with the increase of cardiac output, this means that the patient has abnormal response to exercise, and this need sophisticated graphs to be plotted before we can diagnose exercise-induced pulmonary hypertension. But we have a different scenario. If the patient has mean pulmonary pressure of more than 20 with low pulmonary vascular resistance and low wedge pressure, this patient usually have elevated pulmonary blood flow, and this do not fail any criteria of pre or post-capillary pulmonary hypertension. And this is called now unclassified pulmonary hypertension. This occurs in patients with high cardiac output like congenital heart disease, liver disease, thyrotoxicosis. And the new classification of pulmonary hypertension now highlighted the importance of classification of idiopathic group into non-responder and acute responder. The management is completely different, and the prognosis is completely different. وبالتالي it's very important to identify which patient is responder and which patient is non-responder. The group 1.5 pulmonary arterial hypertension with feature of venous or capillary involvement. Now it has highlighted in the classification. This patient has very bad prognosis, and eventually they need lung transplantation. The group 2 and 3 now changed from BH due to into BH associated with, which is better describing the complex etiology of pulmonary hypertension in patients with left heart disease, in patients with lung disease. And sleep disorders has been removed from the classification because it does not cause as much pulmonary hypertension in real life. Group 4 is now BH associated with and not due to pulmonary obstruction, because usually those patients has combination of obstruction by blood clots and a microvascular disease, which is also similar to the idiopathic type. Now in the group 5, which is multifactorial, we have the chronic renal failure with or without hemodialysis in a very clear statement that this patient has combined form or multifactorial form in a group 5 pulmonary hypertension. The symptoms of pulmonary hypertension at early stage is usually overlap with many diseases like bronchial asthma, like anemia, like different etiologies, and usually the patient present late, and the main task of the guidelines is to raise the suspicion of pulmonary hypertension for early diagnosis and emphasize on the fast track referral to BH centers. And the second objective is to identify the underlying etiologies, identify the comorbidities, and do a comprehensive risk assessment. And he looked here, the echocardiography is usually the first modality to screen patients with suspected pulmonary hypertension clinically. And we look at the peak tricuspid regurgitation velocity. In a patient with peak tricuspid regurgitation velocity exceeding 3.4, this patient has high probability for pulmonary hypertension, and further investigation should be done. If the patient has big tricuspid velocity of 2.8 or less, and no indirect signs of pulmonary hypertension and no other risk factors for pulmonary hypertension, other etiology should be searched for, and the patient with value in between, this is depend according if the patient has indirect signs of pulmonary hypertension, this will be considered a high probability. If no, and the patient has risk factor, we should go for further investigations. And if no indirect signs of hypertension and no risk factors, the patient should have a regular follow-up by transthoracic echo. And this example is very obvious. No one will miss this patient with markedly dilated right side, moderate to severe tricuspid incompetence, markedly compressed LV with D-shaped septum. However, we have these indirect signs to help us to detect pulmonary hypertension in patients with early stage or trivial tricuspid regurgitation when we couldn't adequately trace the tricuspid jet velocity. And the guidelines added the new parameter, which is a very simple parameter to non-invasively assess the ventricular arterial covering of the right ventricle, which is TAPSE to systolic pulmonary systolic pressure ratio. Simply dividing the TAPSE by the systolic pulmonary pressure in the echo. The patient with low ratio, this patient means that he started to have uncoupling of the right ventricle, and this even now incorporated in the risk stratification of patient. And this is example of patient with trivial tricuspid regurg and minimal or subtle change at the septum, minimal flattening of the septum that could be easily missed. But if we looked at the RV acceleration time, this acceleration time is shorter. It is 85. The normal is above 105. And if we looked at the diagnostic algorithm, no major changes has been done. We usually suspect pulmonary hypertension clinically and start with echocardiography screening. Then we have to exclude the most common etiologies of pulmonary hypertension, which are the lung disease of group 3 and group 2, which is heart disease. And usually at this stage, congenital heart disease should be excluded by transthoracic and or transesophageal echo or CT heart. And then the guidelines emphasize on the exclusion of chronic thromboembolic hypertension at the third level of diagnosis, because this patient has a potential for even normalization of their condition. This is one of the only chronic pulmonary hypertension that might be curable by surgery. Then the idiopathic pulmonary hypertension, heritable or drug-induced, usually come at the end of the diagnostic algorithm. Idiopathic pulmonary hypertension should be done by exclusion after extensive follow-up. And as you can see here, echocardiography is a class 1 indication, CT chest is a class 2A indication for all patients with suspected pulmonary hypertension. Routine biochemistry, immunology, HIV testing should be performed. Thyroid function is very important. Abdominal ultrasound, especially in our country, to rule out liver disease and portal hypertension is very important. VQ scan is the most sensitive way to rule out thromboembolic pulmonary hypertension with almost 100% sensitivity for detecting chronic thromboembolic hypertension. A negative VQ scan means this patient does not has chronic thromboembolic pulmonary hypertension. CT pulmonary angio is usually done after a positive VQ scan. And if you look at the pulmonary arterial hypertension, this group is heterogeneous. However, they share the same pathophysiology of medial hypertrophy, intimal narrowing, and plexiform lesions. And if you look here, usually the workup should be performed extensively to diagnose those patients, except for patients with congenital heart disease, which is usually excluded early in the diagnostic algorithm. The new guidelines highlight the importance of screening of patients with connective tissue disorder, particularly scleroderma, which has a very high risk of developing pulmonary arterial hypertension. If you look here, annual evaluation for any patients with scleroderma is class 1 indication, and if the patient has long disease, meaning أكتر من 3 years or abnormal vital capacity, this patient should goes through a detect algorithm, which is an algorithm dedicated mainly to exclude pulmonary hypertension in patient with scleroderma, and as emphasis on how important to rule out pulmonary hypertension scleroderma, if the patient with scleroderma has unexplained dyspnea with no obvious etiology in the non-invasive diagnostic modality, right heart cath is even recommended as a class 1 indication. Right heart catheterization is usually done at the end of the algorithm when we have a preliminary diagnosis, so we don't go for right heart cath except after we have almost the diagnosis now to confirm and to risk stratify the patient. Right heart cath should be performed in PH expert center. If the patient has right heart cath in a PH expert center, the adverse event is very, very low. Why? Because not the procedure is difficult, but because those type of patients are exposed to many complications during the procedure. Now the guidelines add a very clear statement about the fluid challenge test. If the patient has clinical suspicion of left heart disease pulmonary hypertension, for example, HFpEF, and the patient was found to have a pulmonary wedge pressure of less than 15 in the right heart cath. Now we can do a fluid challenge, and it was well described in the pulmonary hypertension to give the patient 500 milliliter of saline over 10 minutes and to measure again the pulmonary wedge pressure. If it's more than 18 or 18 millimeter mercury, this is suggestive of HFpEF. However, the evidence is not that strong for this procedure. One of the most important parameters that should be performed in each right heart cath for patients with either idiopathic, heritable, or drug-induced pulmonary arterial hypertension is acute vasoreactivity using nitric oxide, iloprost, or ibuprostenol. Unfortunately, adenosine, which is the cheaper of those drugs, are now no more in the recent guidelines, should be performed to look at which patient show acute vasoreactivity, and this patient that has a mean barometric pressure of 60, and after adenosine infusion, the mean decreased to 30. Those patients usually behave very well. The diagnosis of acute vasoreactivity depends on decrease in mean barometric pressure of 10 millimeter mercury or more, with absolute decrease to less than 40, with no decrease in cardiac output. So cardiac output has to increase or at least to be the same. And those type of patient has show a very good response to medical treatment. As this example of reverse RV remodeling in patient who started calcium channel blocker in few months, response ده في أقل من 6 months. And it's extremely important to follow up the acute responder after starting calcium channel blocker, because almost 50% of those patients will lose vasoreactivity with time. And if the patient loses vasoreactivity, we have to add a BAH-specific therapy. We can continue smaller dose of calcium channel blocker. So most of the patient, more than 90% of patients are non-vasoreactive. So the guidelines now has an extensive way for risk assessment and included a new parameter like cardiac MRI for to be added in the risk stratification. It depends only on clinical findings, presence of heart failure, symptoms, syncope, 6-minute walk test, biomarker, BNP or NT-proBNP, transthoracic echocardiography, MRI parameters, and hemodynamic parameters. And we have to know that patients with high risk features they has more than 20% annual mortality rate. And the main aim on the target of our management is to move the patient from the red or the yellow zone to the green zone. And on follow-up, we have a less extensive and simplified 4-strata risk. So the patient just need to be assessed clinically to know the WHO function class. 6-minute walk test should be done, and BMB or NT-proBNP should be done. And the patient then classified according to these parameters into low risk, intermediate low risk, or intermediate high risk, or high risk. And if we looked at this, the management algorithm for patients with pulmonary arterial hypertension, first we have general measures, then according to the strata of the patient or risk stratification of patient, we will start the medical treatment. For the general measures, we have this patient is usually you should have supervised exercise. Maybe ده ممكن يكون underused in Egypt. Psychological support extremely important. معظمهم they are young females in childbearing period. Immunization is very important. Diuretic treatment and long oxygen therapy if the patient has partial pressure of oxygen of less than 60. And the presence of iron deficiency anemia, correction of iron status is very important. All are class 1 recommendations. Anticoagulation is not generally recommended in patients with pulmonary hypertension, might be used according to individualized decision, and in some patients it carry increased risk, like in patients with scleroderma. So use of anticoagulation for pulmonary hypertension scleroderma patient increase mortality. Use of ACE inhibitor, ARBs, ARNIs, and SGLT2 inhibitor, beta blocker, or ivabradine are class 3 indication until now. The choice of anesthesia في previous guidelines was the epidural rather than general anesthesia was preferred. Now this changes to we have to weight the risk benefit, and we have need a heart team discussion and discussion with the MDT discussion with the anesthesia cardiologist and the surgeon. So for patients or women with childbearing potential, this patient should be advised against being pregnant, and usually this entails psychological support. It's not an easy to tell a patient at the age of 20 or 30 to not get pregnant, and the contraceptive advice should be performed early in the disease. Genetic counseling is now being added to the guidelines. And the patient should know the teratogenic effect mainly of endothelin receptor blocker and riociguat, so no options during pregnancy except phosphodiesterase inhibitors and prostacyclin. And these are the 3 main pathological pathways involved in pathophysiology of pulmonary arterial hypertension. We have the endothelin pathway, nitric oxide pathway, and the prostacyclin pathway. And because of the disease is aggressive with high mortality, you have to target more than one pathway upfront and not in a sequential way, like in heart failure or like malignancy being treated. And the aim all is to achieve low risk status or to escalate. So patient with low or intermediate risk, we have to start with upfront combination therapy, mainly endothelin receptor blocker plus phosphodiesterase inhibitors. Patient with high risk should include oral endothelin receptor blocker, phosphodiesterase, and prostacyclin, either infusion, IV, or subcutaneous. And then follow-up is extremely important. And then we look at the simplified risk stratification, whether the patient is low or intermediate low or intermediate high or high risk. We have to move the patient to low risk status. And if the patient stayed in the intermediate low status, we have to add another oral treatment, which is selexipag, IP receptor agonist, or switching phosphodiesterase inhibitor from phosphodiesterase inhibitor to cyclase guanylate stimulator. And if the patient is still in intermediate high risk or high risk, this patient should start prostacyclin and should be evaluated for lung transplantation. And we have a different combination, and we have a very complex combination strategies for treatment of patients with pulmonary hypertension. However, the evidence is strong for initial combination therapy with ambrisentan and tadalafil. That can based on the landmark trial, ambition trial, with a class 1 indication. Initial combination therapy with macitentan and tadalafil. Initial combination therapy with other insulin receptor blocker and phosphodiesterase inhibitor is class 2 indication. And if you look here, no patient we will start with him as a monotherapy except a patient with acute vasoreactivity. All patients, either low risk or intermediate risk, should start combination therapy. However, Triton trial, which addresses the question whether to start a triple combination therapy as upfront or not, and it was negative trial, so no recommendation to start upfront combination therapy in patients with low intermediate risk as a triple therapy. And this is how we follow our patient. We look at the risk status every 3 to 4 months, and we assess the 6-minute walk test, we do blood test, most importantly the internal proBNP. We look at echocardiography. We might repeat MRI every 6 months if this is available. The right heart cath could be repeated if the patient started a new treatment and if the patient show worsening, and if the patient are considered for lung transplantation. So we have another important entity with a relatively bad prognosis with pulmonary arterial hypertension, with portal hypertension. We might face this in our country. They develop in 2 to 6% of patients with portal hypertension, either with or without liver disease. We have to differentiate this form from the pulmonary vascular dilatation that occurs sometimes with liver disease, which is mainly entailing high cardiac output rather than a true pulmonary hypertension. A patient with portal pulmonary hypertension should be differentiated between having true pulmonary arterial hypertension or having unclassified pulmonary hypertension, which mean increased cardiac output rather than increase in pulmonary vascular resistance. And in patients with portal hypertension, initial monotherapy, this patient has a lot of comorbidities, and it's difficult to start as a combination therapy. Usually we start initial combination therapy, initial monotherapy as a class 2A indication. Liver transplantation should be considered if the pulmonary vascular resistance is normal or normal on medical treatment. Pulmonary arterial hypertension associated with congenital heart disease is now a better simplified in the new guidelines. It's very easy. However, the recommendation is to do the decision making for closure or not to close shunt should be done by experts, not just by reading these numbers and start to apply it. So patient with shunt and pulmonary vascular resistance of less than 3 is a class 1 indication to close the shunt. Patient with pulmonary vascular resistance between 3 and 5, we should consider closing this shunt. And patient with pulmonary vascular resistance more than 5, this patient is a class 3 to be closed. However, in some expert center and after MDT discussion, heart team discussion, this patient might have the opportunity to close the shunt. In patient with pulmonary arterial hypertension that develop persistent after shunt closure, we might see some patient with ASD closure, and then they have a persistent pulmonary hypertension over time. We treat those patients the same like pulmonary arterial hypertension. We start with initial combination therapy. However, in patients with Eisenmenger syndrome, we usually start with monotherapy, and most of the evidence are with both intense therapy. And if we go quickly through the pulmonary hypertension associated with left heart disease, actually the guidelines did not say a lot about or not enough data to have a very clear recommendations for pulmonary hypertension associated with left heart disease, except that pulmonary arterial specific treatment is not recommended for group 2 pulmonary hypertension. And it's very important to look at whether the patient is early in disease with just backflow and reversible cause of pulmonary hypertension, and patient with late disease with increase in pulmonary vascular resistance as the most relevant number of pulmonary vascular resistance that was associated with worse outcome was 5 Wood units. However, we usually do not do right heart cath for those type of patients, and the guidelines recommend doing right heart cath if this might change the decision making. So in patients with complex valvular heart disease, advanced disease, impaired right ventricle, very high pulmonary hypertension, زمان كنا بنسميه out of proportion pulmonary hypertension, this patient might undergo right heart cath to help decision making before intervention or surgery. And as we can see, drug approved for pulmonary arterial hypertension are not recommended in patients with pulmonary hypertension due to left heart disease. But specifically for the phosphodiesterase inhibitors and their relation to heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, the guidelines has no recommendation can be given for this group of drugs. As we know now, we have patients that might get some benefit from phosphodiesterase inhibitor in patients with HFrEF. However, all these trials included patients who was isolated post-capillary and not with combined pre and post-capillary, so no conclusion could be done. And if you look at the group C pulmonary hypertension, usually we have to refer those group of patients to a pulmonologist, and the PH-specific therapy are not recommended except inhaled treprostinil with a very weak evidence. It's a very important group of patients, group 5 pulmonary hypertension, group 4 pulmonary hypertension, the patient with chronic thromboembolic hypertension. The definition is the same. This patient has to have symptoms, then he has to has signs of obstructive blood clots, and at least 3 months of adequate anticoagulation. This patient usually has a combination of obstruction in major arteries and microvascular disease with plexiform lesion like the same we found in idiopathic type. Some VQ scan and CT pulmonary angio, as we discussed already, are the main diagnostic modality. Then the patient should be referred to a PH expert center. Pulmonary endarterectomy is the class 1 indication if the patient is low risk and is the patient anatomy and the proximal disease is favorable for surgery. If the patient is high risk or the patient has peripheral disease, BBA or balloon angioplasty is now class 1 indication. Riociguat is a drug approved for treatment of inoperable patients with CTEPH or residual hypertension after surgery. And at last and not least, the guidelines emphasize the importance of MDT team for assessment for decision making in patients with pulmonary hypertension. And thank you for your attention.
Thank you, Dr. Ahmed, for these elegant and comprehensive lectures. I want to ask you actually 2 questions. If there is a cut-off pressures that you prevent females from get pregnancy, definitely if more than 5, it's contraindicated. But when you tell her, please don't go to pregnancy. The second is, what's preferred calcium channel blocker if you used for this hypertension vasoactive?
For the first question, there is no cutoff value for telling the patient not to get pregnant. Any patient with fulfilling the diagnostic features of pulmonary hypertension, particularly pulmonary arterial hypertension, which is the non-curable type, except in for some congenital disease, this patient should be counseled against getting pregnant. However, with the new drugs and new better care, the maternal mortality decreased from 50%. Now it's around 25%. However, this is a huge risk for the mother, and the patient should be counseled against pregnancy with no specific numbers, just diagnosis. Because of pulmonary hypertension, pulmonary arterial hypertension is a progressive disease. So once we diagnose the patient, we anticipate a very steep course. Maybe the literature did not answer how to manage patients with acute vaso who are responder to calcium channel blocker. This patient is very different phenotype and usually behave very well and usually achieve function class 1 status and sometimes normalization of hemodynamics. However, there is no specific studies to address this question.
Okay, thank you. Is there any questions in the floor?
Yes. Thank you, Ahmed, for this elegant presentation. I would like to ask you 2 questions. First, about group 2, because I see a lot of patients coming with secondary pulmonary hypertension due to left side affection, whatever, and are receiving drugs for primary pulmonary hypertension. And you mentioned this should not be done. I would like to listen to your opinion based on the guidelines, number 1. And number 2, for group 4, thromboembolic pulmonary hypertension, what about pulmonary endarterectomy? These patients benefit from this? Do you ask for example, multi-slice CT pulmonary and to check for the size of thrombus occlusion of the main or one of the main branches of the pulmonary artery and to do this surgery? It's a high-risk surgery, but it is important.
Thank you for this question, Professor. هو أول سؤال بالنسبة لجروب 2 pulmonary hypertension. The guidelines is not clear. However, there is no evidence to use any of CBA specific therapy as we already mentioned. However, some patients might have which we called out of proportion pulmonary hypertension. For example, patient with initial diagnosis of HFpEF, but the pulmonary systolic pressure is 100. Those type of patients need a discussion. This patient might undergo right heart cath. The evidence for treatment of combined pre- and post-pulmonary hypertension is very low, very scant studies in the literature. Most of the patients did not got any benefit. However, with exception of phosphodiesterase 5 inhibitors, given the role of this group of drugs in heart failure with either reduced or even preserved in some studies now, like Victoria study for HFrEF. But this patient, the guideline did not put any clear message. Most of those patients, we have to start to follow the heart failure guidelines and not the pulmonary hypertension guidelines. No data at all for the combined form. في study صغيرة كانت معمولة على البيشنت who has persistent pulmonary hypertension after mitral valve replacement, and phosphodiesterase inhibitor increase the mortality. فالداتا is conflicting, and I think this should be done individualized. بس الأكيد إنه no rule for insulin receptor blocker بوزنتين أمبيزانتين or macitentan and rule for prostacyclin. بالنسبة للثرومبو embolic hypertension هي المين treatment for those patients with proximal disease and low risk for surgery is pulmonary endarterectomy. المortality is less than 4%. المين problem هي post operative. Usually all those patients develop acute lung injury and ERDS, and the post operative course is usually stormy. So يعني الاوتكم بيعتمد على الانتنسيف كير بشكل كبير قوي. And this patient, I have some patients that showed normalization of hemodynamics, complete normalization بمين 20 or less after being 60 or more. فيعني اعتقد ان the should be considered very early in the disease. لان الليت بريزنتر بيبقى عندهم microvascular disease, and the surgery is carry a very high risk of mortality, and usually even if the الجراح شال the burden of blood clot, the patient usually has a persistent pulmonary hypertension after the surgery.
Is other questions? So thank you, Dr. Ahmed.
Thank you.
Our next speaker is Professor Magdi Abdelhamid. Actually, that's my pleasure to introduce him because we are waiting for an elegant and interesting lectures as usual.
Thank you very much, Professor Nagwa, for the kind introduction. This is a very difficult topic, the guidelines for non-cardiac surgery, because the last guidelines ESC was 8 years ago. So after 8 years, the new guidelines are released and presented in the last ESC meeting in Barcelona. So I cannot cover all the guidelines in 15 minutes. So quickly, I'm going to focus on very important statements in the guidelines. For example, for any patients will undergo non-cardiac surgery, we have to assess two important points. The first point is the risk for surgery. Is it a low-risk surgery, intermediate risk surgery, or high-risk surgery? And the same for the patient, low-risk patient or high-risk patient, moderate-risk patient. And with the combination of both, we can appreciate that we have different recommendations. Attention, increased attention, high attention. The most complex, of course, will be a high-risk surgery and a high-risk patient. And if the surgery is not time-sensitive, so consider postponing or avoiding surgery, except if it is an urgent surgery. So this is very important slide. Then what's mean by low surgical risk, in which the mortality is less than 1%, intermediate surgical risk 1 to 5% mortality, and high surgical risk more than 5%. So you have to know that low risk, which include the surgery for breast, dental procedures, endocrine surgery, orthopedic minor surgery, etc., etc. While intermediate surgical risk is carotid asymptomatic, like carotid endarterectomy, carotid symptomatic endarterectomy, endovascular aortic aneurysm, intraperitoneal like splenectomy, hiatal hernia repair, intrathoracic, neurological orthopedic major surgery like hip replacement or course, peripheral arterial angioplasty. The high surgical risk is adrenal resection, aortic and major vascular surgery, symptomatic carotid artery surgery, surgery for duodenal pancreatic surgery, liver resection. So also, this is very important slide to know which is considered a low risk, intermediate risk, and high risk. Then the preoperative assessment before non-cardiac surgery. It's very important that management of patients should identify if this surgery is an emergent or urgent surgery. If yes, so we don't have time to do any investigation. If it is not emergency or urgent surgery, time sensitive or not? If it's time sensitive surgery, so multidisciplinary decision of individualized cardiac testing. If time, manage as elective non-cardiac. If we have time, like for example, patients will do surgery for hernia, for example, repair. So we have time. So this is an elective procedure can be managed. So accurate history taking and the clinical examination, including standard lab tests, is class 1 recommendation. Then as long as it's an elective surgery, so advice on stop smoking 4 weeks before at least, and optimized guideline recommended medical therapy. Then according to the age of the patient, if it's less than 65, without any cardiovascular disease, without any cardiovascular disease risk factors, as long as the surgery is low risk, so nothing is needed, while it's, and the same for intermediate surgery risk. But if it is a high risk surgery in patients above the age of 45, then consider to do electrocardiogram and biomarkers like NT-proBNP, which is class 2A recommendation. Above the age of 65, or in the presence of cardiovascular risk factors, for low-risk surgery, nothing is needed, while for intermediate risk, the same ECG, biomarkers, and in addition, functional capacity assessment, which is class 2A recommendation, and the same for high-risk surgery, biomarkers, ECG, class 1A, and functional capacity, class 2A recommendation. Patients with established cardiovascular disease, and this is the most important type of patients that we are seeing in the daily clinical practice, that your colleague, surgeons who referred a patient who had, for example, coronary artery disease or heart failure, asking for recommendations before doing non-cardiac surgery. What can we do? A low-risk surgery, so nothing is needed. And for intermediate risk surgery, ECG biomarkers should be done, of course. Functional capacity is the same. And for high-risk surgery, in addition to both, we need a cardiology consultation and the multidisciplinary decision. We have to discuss the risk for the patients, the perioperative complications that could happen. So in all patients scheduled for non-cardiac surgery, an accurate history, clinical examination recommended class 1C, preoperative risk assessment at the same time as non-cardiac surgery is proposed. If time allows, it's recommended to optimize guideline recommended treatment for cardiovascular disease, and risk factors the same. In patients with a family history of genetic cardiomyopathy, it's recommended to perform ECG and transthoracic echo before non-cardiac surgery, regardless of age and regardless of symptoms. And in patients the age of 45 to 65 without signs, symptoms, or history of cardiovascular disease, ECG and biomarkers should be considered before high-risk surgery. The new recommendations for patients with newly detected murmur and symptoms or signs of cardiovascular disease, echo, of course, is highly recommended, class 1C, and in the presence of murmur suggesting clinically significant pathology, echo is recommended. And in patients with newly detected murmur but without signs or symptoms of cardiovascular disease, the recommendation to do an echo and before moderate and high-risk surgery is class 2A. So this slide answers the question that every patient we are seeing in the hospital doing for a minor surgery and low-risk surgery and without any indications, echocardiography. So we have to follow the guidelines to know which patients that you shouldn't send him to do an echo before non-cardiac surgery. For previously unknown angina in patients scheduled for elective non-cardiac surgery, chest pain, or other symptoms suggestive of undetected coronary artery disease. Of course, further diagnostic workup is recommended class 1, and in a patient in need of acute non-cardiac surgery, chest pain, or other symptoms suggestive of coronary artery disease, multidisciplinary assessment approach is recommended to choose a treatment with the lowest total risk for the patient. Patients with dyspnea and/or peripheral edema, ECG and NT-proBNP, of course, are recommended before non-cardiac surgery, and in patients with the same symptoms and high level of NT-proBNP, then transthoracic echo is recommended before non-cardiac surgery. Professor Ayman Saleh, حضرتك chairperson في السيشن ده, I'm sorry. طبعا I'd like to welcome Professor Ayman Saleh, Professor Nabil Farag. I'm sorry I started before welcoming Professor Nabil, and Professor Ayman is coming. Welcome, Professor Ayman. So in patients with dyspnea and peripheral edema and elevated NT-proBNP, transthoracic echo is recommended. So ECG and NT-proBNP before doing echocardiography. And we have different risk score calculators. In 1999, we have the revised cardiac risk index, and then we have different risk scores which can be used to estimate the perioperative risk of morbidity and mortality. The most recent one is from the American University of Beirut, cardiovascular risk index based on history, symptoms of heart disease, angina, dyspnea, age, anemia, vascular surgery, emergent surgery, and each variable can be considered to take 1 point, and then you have to estimate whether low risk, intermediate risk, and high risk. And this indicates not only the perioperative in hospital, but also indicates the 30-day risk of death, myocardial infarction, or stroke. So in patients above the age of 70, scheduled to undergo intermediate or high-risk surgery, frailty screening should be considered. This is very important. So to assess the functional capacity, and it's correlated with the outcome, because poor functional capacity is associated with poor outcome post-operative. And adjusting risk assessments according to self-reported ability to climb 2 flights of stairs should be considered in patients referred for intermediate or high-risk surgery. Is class 2 a recommendation. So the recommended measurements to assess and to detect the risk of post-operative complications. So before non-cardiac surgery, electrocardiogram, high-sensitive troponin before surgery, and then 24 hours, 48 hours after surgery, because a rise in high-sensitive troponin indicates a perioperative myocardial infarction. If the high-sensitive troponin change more than the upper limit of normal, so doing a baseline troponin can identify if the patients develop an event post-operatively, the rise in high-sensitive troponin indicating, in addition to clinical assessment and electrocardiogram, that these patients develop post-operative myocardial infarction. So in patients above the age of 65, symptom signs suggestive cardiovascular disease, preoperative 12-lead ECG before intermediate and high-risk non-cardiac surgery, and also high-sensitive troponin, T or I, class 1B recommendation above the age of 65, and patients with cardiovascular disease or cardiovascular disease risk factors. In patients who have no cardiovascular disease and risk factors also above the age of 65, NT-proBNP is 2A. So high-sensitive troponin is class 1, while NT-proBNP is class 2A recommendation in those high-risk patients. And very important that preoperative ECG, high-sensitive troponin, and NT-proBNP are not routinely recommended. This is class 3 recommendation. So look for the risk before asking for the investigation. So transthoracic echo is recommended in patients with poor functional capacity and or high NT-proBNP level, or if murmurs are detected before high-risk non-cardiac surgery. This is class 1B recommendation. The same for echo in patients with suspected new cardiovascular disease or unexplained signs or symptoms before high-risk non-cardiac surgery. This is class 2A recommendation. Also, echo is class 2B recommendation in patients with poor functional capacity, abnormal ECG, high level of NT-proBNP, or one or more of clinical risk factors before intermediate risk. So in high-risk surgery, it's class 2A, while intermediate risk surgery is class 2B recommendation. Routine preoperative evaluation of LV function is not recommended. This is class 3 recommendation. So don't look for the ejection fraction in patients with low risk for surgery and low risk for cardiovascular disease. There is no need to do echo, which is, of course, is costly investigation. So stress imaging is recommended before high-risk elective non-cardiac surgery in patients with poor functional capacity and the high likelihood of coronary artery disease or high clinical risk. This is class 1B recommendation. Stress imaging should be considered before high-risk non-cardiac surgery in asymptomatic patients with poor functional capacity and previous history of PCI or CABG, class 2A recommendation. Stress imaging may be considered before intermediate risk non-cardiac surgery when ischemia is of concern in patients with clinical risk factors and poor functional capacity, and this is class 2B recommendation. So stress imaging, again, is not recommended routinely before non-cardiac surgery. It's recommended to use the same indications for invasive coronary angiography and revascularization preoperatively as in non-surgical setting, as long as this is an elective surgery, not an urgent surgery. CT coronary angiography should be considered throughout coronary artery disease in patients suspected chronic coronary syndrome or biomarker negative non-STEMI ACS in case of low to intermediate clinical likelihood of coronary artery disease, or in patients not suitable for non-invasive functional testing undergoing non-urgent, intermediate, and high-risk non-cardiac surgery. So the rule of CT coronary angiography is recommended as class 2A recommendation. Preoperative coronary angiography may be considered in stable patients undergoing elective surgical carotid endarterectomy because those patients are at high risk and many of those patients have left main disease. This is class 2B recommendation. So routine preoperative coronary angiography is not recommended in stable patients undergoing low or intermediate risk non-cardiac surgery. Smoking cessation at least 4 weeks, class 1B, control of cardiovascular risk factors including blood pressure, dyslipidemia, hemoglobin A1C is recommended before non-cardiac surgery. In patients with an indication of statin should be considered perioperatively, of course. Preoperative initiation of beta blockers in advance of high-risk non-cardiac surgery may be considered in patients who have 2 or more of clinical risk factors to reduce perioperative myocardial infarction. So beta blocker has a role, but it's considered a class 2B recommendation. And preoperative initiation of beta blocker in advance of non-cardiac surgery may be considered in patients who have known coronary artery disease or myocardial ischemia. But routine initiation of beta blocker before surgery is class 3 recommendation, which is not indicated. Perioperative continuation of beta blocker is recommended in patients currently receiving this medication. We will continue on beta blocker as long as the patient is on beta blocker, and the same for statins. In patients with stable heart failure, perioperative continuation of RAS inhibitors may be considered class 2B recommendation. Which drug should be interrupted and be stopped? So look for the guidelines. In patients without heart failure, withholding RAS inhibitors on the day of surgery should be considered, of course, to prevent perioperative hypotension. This is class 2A recommendation. And for patients on diuretics to treat hypertension, transient discontinuation of diuretics on the day of surgery also is class 2A recommendation. And recently we are using SGLT2 inhibitors, which should be stopped at least 3 days before intermediate and high-risk surgery, and this is class 2A recommendation. So the bleeding risk according to type of surgery, and this is very important topic, the risk for bleeding in patients using dual antiplatelet therapy or monotherapy with antiplatelets, undergoing for a major surgery, and the risk of bleeding, when to stop. So I need more 15 minutes to continue with this topic, please. So very quickly, surgery with minor bleeding risk, such as cataract or glaucoma procedure, dental procedures, endoscopy without biopsy, surgery with low bleeding risk, abdominal surgery, cholecystectomy, breast surgery, and others, surgery with high bleeding risk, abdominal surgery with liver biopsy, extensive cancer surgery, neurosurgery, major orthopedic surgery. We have many urological surgeries such as prostatectomy and bladder tumor resection. These surgeries are associated with heroic bleeding. So be very cautiously when patients are who is using antiplatelet therapy. So these recommendations for management of antiplatelet therapy in patients undergoing non-cardiac surgery. Look, what's the guidelines say? Say that high bleeding risk related to non-cardiac surgery. If yes, high thrombotic risk as well, like patients underwent PCI less than a month, or patients who had acute coronary syndrome less than 3 months, or high-risk patient for stent thrombosis. So we have both high-risk bleeding, high-risk patient. Look for the surgery. Is it time-sensitive, non-cardiac surgery? Yes. So bridge with glycoprotein 2B receptor antagonist or cangrelor intravenous to be stopped immediately before surgery. No, it is not time-sensitive. So defer, stop, postpone, will not do the surgery because high risk of bleeding and high risk thrombotic risk. So if no, it's not a high risk, it's not a high bleeding risk, so continue DAPT, not a high thrombotic risk, continue aspirin. Interruption of P2Y12 inhibitors is class 2A recommendation, but when you need to stop B2Y12 inhibitors, ticagrelor stopped 3-5 days before surgery, clopidogrel should be stopped 5 days before surgery, and prasugrel 7 days before surgery. This is class 1 recommendation. So P2Y12 inhibitor interruption after PCI before elective non-cardiac surgery, patients with ACS at index PCI or other high ischemic risk features. If yes, it's class 3 to do anything before 3 months. Wait at least for 3 months. Then from 3 months to 6 months, class 2B recommendation. And after 12 months, which is the standard of care to give dual antiplatelet therapy 1 year. So after that, it's class 1 recommendation. And if no, if it's not an ACS, so a class 3, don't do it. Don't stop within the first month. Then after the first month, up to the 6th month, it's class 2A, and this is the guideline recommendation to give DAPT therapy in stable patients doing PCI only for 6 months. And after 6 months, you can stop, and it's class 1 recommendation. So bridging with intravenous antiplatelet agents, you will stop clopidogrel 5 days, or prasugrel 7 days, or ticagrelor 3-5 days, and you will do the surgery. And before surgery, you can give tirofiban or eptifibatide, or you can give infusion of B2Y12 inhibitors, intravenous cangrelor, which will be stopped for 6 hours before surgery. Do your surgery. After surgery, resume DAPT therapy, or you can give also the intravenous cangrelor until you start the dual antiplatelet therapy. Very nice recommendations when to do bridging with these agents. So it's recommended to delay elective non-cardiac surgery until 6 months after elective PCI, and after elective PCI, it's recommended to delay time-sensitive non-cardiac surgery until minimum 1 month of DAPT treatment. And in patients with recent PCI, it's recommended that management of antiplatelet is discussed between surgeon and the cardiologist, anesthesiologist. In high-risk patients with recent PCI, like STEMI patients or high-risk non-STEMI patients, adapt duration of at least 3 months should be considered before time-sensitive non-cardiac surgery. Continuation of medication with the previous PCI, it's recommended to continue aspirin perioperatively if bleeding risk allows. And the interval for drug interruption before non-cardiac surgery if the interruption of P2Y inhibitor, P2Y12 inhibitor is indicated. We mentioned how many days you should stop clopidogrel, tica, and prasugrel. For patients undergoing high bleeding risk, like intracranial spinal neurosurgery, it's recommended to interrupt aspirin for at least 1 week before neurosurgery, because the risk of bleeding is very high. In patients without history of PCI, interruption of aspirin for at least 3 days before non-cardiac surgery may be considered if the bleeding risk outweighs the ischemic risk to reduce bleeding, class 2B recommendation. If antiplatelet therapy has been interrupted before surgical procedure, it's recommended to restart it within 48 hours post-surgery. This is class 1C recommendation. Oral anticoagulation, very problematic. Patients on warfarin, patients on NOACs, coming for urgent surgery. What can we do? The same high risk, bleeding risk or not, high thrombotic risk or not. Yes, it's high bleeding risk surgery. Yes, it is a high thrombotic risk patient, like mechanical valve prosthesis on VKA. So in such case, bridge is very important, which is class 2 recommendation. Patients VKA or NOAC bridge class 2B recommendation if selected patients not a mechanical valve with high thrombotic risk. If you have the option to defer and postpone surgery, it will be better. If it is not high thrombotic risk, so interrupt only the anticoagulation. Bridging is not recommended, class 3 recommendation. It's not a high bleeding risk, and the patients on VKA continue with INR in lower level or short interruption, which is class 1, no need for bridging. And patients on NOAC, you will stop at least 5 half-lives of the drug, short interruption, class 1, and again, bridging is not recommended. So this is a very detailed scheme or algorithm for how to do this perioperative management of non-vitamin K antagonist oral anticoagulant according to the peri-procedure risk of bleeding. Minor bleeding risk surgery or intermediate or high risk surgery, which drug, dabigatran or rivaroxaban or apixaban, stop before or may skip the evening dose in minor bleeding risk surgery, while in high bleeding risk surgery, no NOACs and no bridging, and then you can do the surgery and to be restarted later on 48 hours to 72 hours after surgery. So in low-risk surgery, if you see, you just escape the evening dose in very minor bleeding risk, and then after doing the procedure or surgery, restart NOACs 6 hours after surgery, like, for example, dental procedures, which is commonly seen in the daily practice. So timing of the last NOAC dose before elective non-cardiac surgery according to the renal function. This is also very interesting to look for the low bleeding risk, the high bleeding risk, and renal function, and according to the different estimated GFR, you can appreciate the timing of the last NOAC dose before elective non-cardiac surgery according to renal function, 24 hours or more than 48 hours according to, in the presence of high bleeding risk, giving these NOACs. Suggested strategy for reversal of non-vitamin K oral anticoagulation. We know the antidote of dabigatran, which is idarucizumab, yes, which can be given to reverse the action of NOACs immediately, dabigatran. Again, we have many slides. I don't need to take much time in this. The same continuation of medications, bridging with low molecular weight heparin, class 2A recommendation, in needed in patients with mechanical aortic valve replacement and any thrombotic risk factor, all generation of mechanical aortic valve, mechanical mitral or tricuspid valve. So bridging with unfractionated heparin or low molecular weight heparin should be considered if you need to do interruption in those high risk surgery, which is class 2A. Again, and very important, bridging of oral anticoagulation is not recommended in patients with low, moderate thrombotic risk undergoing non-cardiac surgery. In the daily practice, you see patients, the surgeon, right, Clexane, heparin, in a very minor surgery and stop the warfarin, which is not the case. This is class 3 as long as it is the low moderate thrombotic risk non-cardiac surgery. And then you will start to give the anticoagulation again. And this is management of acute chronic coronary syndrome scheduled for non-cardiac surgery. Will not take much time. Aortic stenosis, it depends according to the severity, according to heart failure or not, LV function, high-risk surgery or not. We can do aortic valve surgery or TAVI before elective surgery. Otherwise, in high-risk surgery, you can consider balloon aortic valvuloplasty, which is class 2B recommendation before non-cardiac surgery if feasible, or non-cardiac surgery under strict monitoring. This is very important. And with secondary mitral regurgitation, the same optimal guideline directed medical therapy. Sometimes we need to do mitral valve edge-to-edge repair, class 2A recommendation in patients with will be subjected to intermediate risk or high risk non-cardiac surgery. And then the perioperative management of arrhythmias, very important, SVT, idiopathic VT, instruction functional normal heart, the VT, and the role of cardioversion in patients, for example, have very rapid atrial fibrillation with hemodynamic disturbance, the role of beta blocker in SVT and ventricular tachycardia. Again, the last slide, this is the patient-related and surgery-related risk factors which should be considered when assessing the perioperative risk in patients with pulmonary hypertension. The high-risk patients, of course, who have more function class, reduced 6-minute walk distance, coronary artery disease, previous pulmonary embolism, chronic renal insufficiency, RV dysfunction, who will be subjected to emergent surgery, duration of anesthesia more than 3 hours, intraoperative requirement for vasopressors. So this is the recommendation for patients with pulmonary hypertension who will be undergoing non-cardiac surgery, which was an MD exam just a few days ago, how to deal with the patients with pulmonary hypertension undergoing non-cardiac surgery. So for that, thank you very much for your attention because I have many slides.
اولا بشكر حضرتك يعني على الايفنت. هو ايفنت في غايه الاهميه، كل توبيك في غايه الاهميه. انا ليا سؤال واقتراحين لو سمحت. السؤال الاولاني خاص بالتروبونين هاي سنسيتيفيتي، استخدامه بيري اوبرتيف از ماركر فور مايوكاردال انفارج. بيري اوبرتيف احنا التروبونين حضرتك سواء هاي بيعلى مع تايبس اوف سيرجريز، مش بس مع الانفارج، بالذات الحاجات اللي فيها تيومرز او جي اي تي او بيج انسيجنز في فهنا الحته دي محتاجين حضرتك بس تاكد لنا البوزيشن بتاع التروبونين في السيتويشن دي كمقياس لحدوث بيري مايوكارد انفارج. ده السؤال.
هو طبعا الاهم هو طبعا البيز لاين اللي هو البيفور to compare to see the serial rise and drop of troponin. So if you have a baseline value of high sensitive troponin, and not only the high sensitive troponin, it should be with clinical assessment and electrocardiogram. I will consider the diagnosis of perioperative myocardial infarction. So the guidelines recommend class 1 to do preoperative in patients at high surgical risk, high thrombotic risk and high risk surgery to do baseline high sensitive troponin.
اوكي، بس انا عايز اكد على الزملاء ان الانفكشنز واحد بيفتحوا بطنه على انه عنده بريتونايتس وهو عنده بريتونايتس او عنده مالجنسي او عنده حاجه، these type of disease and surgeries هي لوحدها بتعلي تروبونين، فبالتالي حتى لو هاي سيستيف فمحتاجين ان احنا لا طبعا مظبوط كلام حضرتك مظبوط، بس لازم نبقى فيري كوشس انه ممكن يعلى برضه، لان هو كان الاول انفكشن بانفكشن وتروما ميجور سيرجي مثلا عملوا اكسجين عملوا واسعه قوي، فبس تذكر ان دي لها بيت فولز ان يبقى التروبونين بيعلى في اسباب مش نتيجه ان حصل انفارج. فزي ما حضرتك قلت ما تتاخدش لوحدها صح مع البيز لاين وتتاخد مع الايكو والاي سي جي واحد.
انا ما اعرفش البراكتس مين بيعمل بايو ماركرز في البري اوبراتيف، يعني مين بيطلب هاي سنسيتيف تروبونين وانتي برون بي،
مش ده الروتين خالص يعني
في الهاي ريسك سيرجري والهاي ريسك بيشنت.
فبس دي ملحوظه عايز اقولها. الاقتراحين لحضرتك، اولا اقتراح متعلق بالشيء القيم اللي هو الجايد لاينز دي، كل واحده منها تستحق انها كل توبيك في المحاضرات بتاعت الثلاثه دول صحيح. مش بقى بقيه اليوم، تستحق انها تبقى جمعيه القلب بتتقدم او تعملها في شكل كيس سيناريوز،
كيس بيس
هتبقى كيس بيس سيناريوز لكل توبيك من التوبيك بتاع الثلاث محاضرات والسيشن دي وغيرها، لانها تستحق هذا. بحيث السيناريوز اللي بنواجهها في الحاله اليوميه هتبقى اقدر على توصيل المعلومه. الاقتراح الثاني اللي هو الجزء يخص مصر في حكايه الهاي ريسيرش، حكايه الترانسبلانتيشن. احنا في مصر معظم مثلا ليفنج ترانسبلانتيشن، مش معظمه كله، بيتم من ليفنج دونرز، في حين بره مصر معظمه بيتم من كادافرز. فهنا الحته دي انا طلب مني من كام شهر من الجمعيه الدوليه للترانسبلانتيشن كمشاركه ان انا اقول مقترح جايد لاينز للدونر والريسيبينت. فاجتهدت وقدمت حاجه واعتمدوها، انما ده اجتهاد شخصي. فانا برضو من ضمن اقتراحاتي ان احنا بما ان مصر فيها الترانسبلانتيشن بالذات في الليفر من ليفنج دونر وليس زي بقيه العالم من ديد، فاعتقد دي برضو محتاجه نظره مننا، ممكن تبقى جزء من سيشن
كونسنسس.
وانا طبعا ابقى سعيد لما اشارك مع حضراتكم. شكرا لحضرتك.
ربنا يخليك.
Thank you, Dr. Magdi. Any question?
تالي عشان الدكتور نبيل بقى.
I have an honor to present Prof. Dr. Nabil Farag with the topic angina with non-obstructive coronary artery disease. What do the guidelines say? Okay.
Thank you very much. First of all, I would like to thank my dear friend, Dr. Magdi Abdelhamid. He's very active in everything, actually, in preparation of the conference, education, and everything. Congratulations, Magdi, for what you are doing. This is actually a very, very interesting topic, which is ischemia with non-obstructive coronary artery disease, which we call it INOCA. And as Dr. Ayman said, I will present this as a case-based study. Actually, this is a real case. This is one of my patients. It's a 45-year-old female patient. She's hypertensive and cigarette smoker, and she has a past history of hysterectomy. She presented to the outpatient clinic with chest tightness radiating to her left shoulder, occurring mainly on exertion. It's like a classic anginal chest pain, and she reported also difficulty in climbing stairs due to her symptoms. On examination, her blood pressure was 140/70, heart rate 66, already taking beta blocker, and her ECG, resting ECG, was normal, and heart rate is 66 per minute. And I asked for a stress test, and the stress test, she was able to exercise for only 3 minutes and 3 seconds, and stopping due to chest pain and leg fatigue associated with 2 millimeter ST segment depression during exercise in infralateral leads, and she was diagnosed as a positive stress test. That's why, based on the symptoms, which is angina, and based on the positive stress test, we decided to go for a coronary angiography. And actually, this is her coronary angiography. And as we see, it was unremarkable. Just if we look carefully at the LED, we have some stagnation of the contrast in the LED. This is only finding for her. And this is another view for the left system. And this is, it looks normal. Only if we look at the proximal part of the LED, you can find some stagnation of the dye. And this is her right coronary artery, to the dominant and normal right coronary artery. Let's go to ischemic heart disease. What's ischemic heart disease? Either we have a chronic coronary syndrome or an acute coronary syndrome. Acute coronary syndrome is either due to obstructive coronary artery disease or a non-obstructive coronary artery disease. Non-obstructive coronary artery disease is what we call INOCA. And in case of acute coronary syndrome, we have unstable angina and an ST or ST elevation MI, and this is due to obstructive coronary artery disease. And we have a myocardial infarction with no obstructive coronary artery disease and what we call MINOCA. So in chronic coronary syndromes, we have INOCA, and acute coronary syndromes, we have MINOCA. Let's go for our subject today, and all of us know that patients with chronic coronary syndromes usually present to the outpatient clinic with one of 6 common scenarios. One of these scenarios is the fifth one. Fifth one is patient with angina and suspected vasospastic or microvascular disease, and this is our interest today, and this is our subject today. We are discussing this very important scenario of presentation of chronic coronary syndromes. Actually, my slides were taken from the European Association of Percutaneous Cardiovascular Association, and these are not guidelines, these are guidance, because actually there is no clear guidelines for patients with INOCA or MINOCA. And if we are talking about INOCA or ischemia with a non-obstructive coronary artery disease, this could be either coronary microvascular dysfunction. Coronary microvascular dysfunction is associated with impairment in coronary physiology and myocardial blood flow in subject with risk factors, and as we see here, smoking, hypertension, diabetes, dyslipidemia, and obesity, and female sex is very important risk factors for patients with coronary microvascular dysfunction, and this represents with a microvascular angina and contribute to myocardial ischemia, or due to vasospastic angina. And all of us know Prinzmetal angina in the past. Prinzmetal angina, if we have a transient vasospasm, we have what we call vasospastic angina. It was previously called Prinzmetal angina. And if we have a persistent vasospasm in the coronary arteries, we will have a myocardial infarction. Let's go to the two endotypes of INOCA. The first endotype is a microvascular angina. Microvascular angina actually is a clinical manifestation of myocardial ischemia caused by either structural remodeling of the microvasculatures. This will lead to fixed reduced microcirculatory conductance. And to assess the microcirculation in this condition, the best drug to be injected in the coronary artery is adenosine. And the second cause of this microvascular angina is a vasomotor disorders affecting the coronary arterioles, leading to dynamic arteriolar obstruction. And the best drug to assess this is the intracoronary injection of acetylcholine. So acetylcholine is used to assess either the vasomotor disorders of the microcirculation or the Prinzmetal angina, which is the vasospastic angina of the epicardial coronary arteries. So there is difference between adenosine use and acetylcholine use to differentiate between both. Unfortunately, both vascular dysfunction mechanisms, both structural remodeling and vasomotor disorders may coexist in the same patient and contributes to the microvascular angina. The second endotype of INOCA is the epicardial vasospastic angina, and epicardial vasospastic angina, all know it is due to a dynamic epicardial coronary obstruction caused by vasomotor disorders, mainly in the media due to smooth muscle cell spasm and contraction. And it was first described in 1959 by Prinzmetal, and all of us know Prinzmetal angina. It is no more used now. It's called vasospastic angina because the patient usually, when he has chest pain or when she has chest pain, there is a transient ST segment elevation in the ECG, and this is the classic of Prinzmetal angina. But we have other forms of vasomotor disorders causing chest pain associated with ST depression or T-wave inversion. Collecting all of this, chest pain, ST elevation, chest pain, ST depression, or T-wave, collecting together, we call vasospastic angina instead of calling them Prinzmetal angina. Microvascular angina and epicardial vasospastic angina can coexist in the same patient again, which is associated with worse prognosis. What is the clinical manifestations of ischemia with no obstructive coronary artery disease? Actually, we have a wide spectrum of symptoms and signs, and usually it is a misdiagnosed as this chest pain is of non-cardiac origin. And because it is misdiagnosed as a non-cardiac origin, definitely this will be under-investigated and under-treated. The most common symptoms of INOCA is angina-like symptoms, but also we have other symptoms like breathlessness, shortness of breath, interscapular chest pain, nausea, vomiting, extreme fatigue, weakness, and sleep, even sleep disturbance. If we look at the short and long-term prognosis of INOCA, INOCA is not a benign disease. INOCA is associated with impairment in the quality of life because of symptoms the patient has. It's associated with high risk of disability. The patient cannot move, cannot climb stairs like the patient I presented. There is a higher incidence of adverse events, including increased mortality, increased morbidity, and healthcare costs. And healthcare costs in the form of higher recurrence of hospital readmissions and the higher rate of repeated coronary angiogram. Also, in patient with INOCA, because the angiogram is normal, this patient usually receive inappropriate treatment. There is inappropriate discontinuation of the anti-angiogenic treatment because the coronary angiogram is normal. Second, there is a paradoxical reassurance to reassure these patients that everything is fine, but the patient has angina and has a microvascular or vasospastic angina. And this is a paradoxical reassurance by the treating physician, and the physician may even refuse the underlying symptoms. And this approach actually is not patient-centered because the patient will continue to have symptoms that will lead to rehospitalization, repeated diagnostic testing, and inappropriate treatment. Let's go to how to diagnose INOCA. Diagnosis of INOCA depends on some non-invasive methods and very important invasive methods. Non-invasive methods, like all of us know, functional imaging, and based on the chronic coronary syndrome guidelines, this functional imaging is preferentially considered if there is a high clinical likelihood of ischemic heart disease or revascularization is likely. And all of this functional, we know all of this functional, or we can ask for a multi-slice CT, multi-slice coronary CT for the anatomy of the vessels, and this is considered based on the chronic coronary syndrome guidelines in low clinical likelihood patients or patient characteristics suggest a high imaging quality. The most important is the invasive methods to detect ischemia in such patients. And I think this is the most important slide I would like to stress on. Because coronary angiography is indicated in such patients, and based on this coronary angiography, we have either equivocal atheroma. And if we have equivocal atheroma, definitely we have to go for physiologic assessment, and physiologic assessment with FFR or IFR. If the FFR is less than 0.8, this is an obstructive form of coronary artery disease and should be treated interventionally. But if the FFR is more than 0.8, this is a non-obstructive form of coronary artery disease. Or if we have from the start no stenosis at all. So if we have either a coronary FFR of more than 0.8 or no atheromas, this is form of non-obstructive coronary artery disease. In this condition, we have to assess the coronary flow reserve. Assessment of the coronary flow reserve is done by intracoronary adenosine. And if we have a coronary flow reserve of less than 2.5, 2.5 folds of the normal or the resting coronary flow, in this condition we have a coronary microvascular dysfunction. But if we have a coronary flow reserve increase by more than 2.5, in this condition we have to consider other diagnosis. We can go for injection of acetylcholine to detect vasospastic angina, either in the epicardial coronary arteries or in the microcirculation. In the microcirculation, if the coronary flow reserve is less than 1.5, this is again of a coronary microvascular dysfunction. And if we have a 90% or more diameter reduction in the epicardial coronary artery, this form of a coronary vasospasm. And this is very important to differentiate between microvascular dysfunction and coronary vasospasm. If we have both coronary flow reserve normal and we don't have epicardial vasospasm or a reduction in the diameter of the coronary arteries by more than 90%, this is a non-cardiac chest pain, and this is a normal patient. How can we manage INOCA? Management of INOCA, like the management of any patient with ischemic heart disease. First, lifestyle factors, diet management, exercise, and weight management. All of this should be considered in patients with INOCA. Risk factor management, and this risk factor should be treated based on the guidelines, or what we call a guideline-directed medical therapy for hypertension, for dyslipidemia, and for diabetes. And the most important is the anti-anginal medication. If we have a microvascular angina, the anti-anginal medication recommended are beta blocker, calcium channel blocker, nicorandil, ranolazine, ivabradine, and trimetazidine. But if we have vasospastic angina, in this condition, beta blockers are contraindicated. And the drug of choice are calcium channel blocker, long-acting nitrates, and nicorandil. In both conditions, we have to use statins and ACE and ARBs. And this is the management. This is the guidelines. Only 2 slides are present in the chronic coronary syndrome guidelines, that use of adenosine is class 2A, use of acetylcholine is class 2B. And this is my last slide, which is the take-home message or the key message we get from this consensus or document consensus by the European Association of Percutaneous Cardiovascular Interventions, that the first message is definitely we have a large proportion of patients undergoing coronary angiography because of angina and evidence of myocardial ischemia, like the patient I presented, but they don't have obstructive coronary artery disease. They have demonstrable ischemia. This is exactly what we call INOCA. INOCA could be either due to coronary microvascular dysfunction alone or in combination with coronary artery disease, or due to epicardial vasospasm, again, alone or in combination with coronary artery disease. In this condition, we have to go for diagnosis of this INOCA. Diagnosis will be done by non-invasive tests, all of these tests, but the most important way to diagnose INOCA is invasive coronary angiography. And by invasive coronary angiography, you can differentiate between microvascular dysfunction and vasospastic angina by use of the guide wires, pressure and flow measurements using adenosine to diagnose coronary microvascular dysfunction, or to use acetylcholine to diagnose vasospastic angina, or what we call before Brenn's metal angina. Based on the diagnosis, we have to go to a stratified approach to the management of INOCA. This stratified approach we mentioned before, lifestyle factors, risk factors, management per cardiovascular disease prevention guidelines. And we have to use pharmacotherapy to alleviate ischemia and symptoms. This is very important, again, because these patients are undertreated and underdiagnosed, underinvestigated. And this is a very important problem. Lastly, I would like to stress on, up till now, there is still lack of in-depth knowledge about INOCA. That's why we have to increase our mechanistic understanding of this important disease and to develop innovative therapies for better management for this actually serious condition. Thank you for your attention.
موضوع مهم جدا وموضوع مهمل، انا حاسس ان هو مهمل، وفريكوينتلي احنا وسط ما بيتعمل مالتي سلايس سي تي الواحد بيشتكي او بيتعمل انجيو، الف مبروك انت سليم. هو مش سليم، هو يكون عنده البلاكس اللي حضرتك شاورت عليها، ان الصبغه بتيجي تقف تتلكع كده، او سلو فلو، او ليجن 10%، ده مش نورمال. هو نان اوبستاك بس مش نورمال. فهو ده كونسيبت بعيد عن ذهننا او بننساه، لكن في غايه الاهميه. فانا بشكر حضرتك على الموضوع ده. الحاجه الثانيه، احنا قد يكون ما عندناش في مصر كونتراست ايكو، وقد يكون ما عندناش في مصر مش كل مكان فيه يعني اف اف ار او اي اف ار او استايل كولين او ادينوزين. انما افكر حضراتكم ان لو احنا عندنا فيري سمبل a good stress technician with a good انجيو او سي تي انجيو، ده هيبقى دوكيومنتنج معقول جدا ان احنا نقول ان احنا عندنا انوكا. انما الانوكا از نوت نورمال، ما هوش زي ما احنا. فبشكر حضرتك على الموضوع ده. لو ليا ان انا اقول اضافه بس، ان هو المايكرو فاسكولار ديزيز جزء منه جينيتك، يعني في ناس عندهم جينيتك بريدisposition، وفي جزء ثاني اللي هو الناس اللي عندهم هايبرجلايسيميا. اي اكيوت هايبرجلايسيميا حتى لو كان ما هوش دايابيتك انما تعرض لستريسفul كونديشن، فالاكيوت هايبرجلايسيميا امبيرز اكيوتلي ذا مايكروفاسكولار سيركيليشن. بس دول اشكرك جدا.
شكرا جزيلا دكتور نبيل. انا برضو كان عندي اضافه كده. حضرتك علقت على الاف اف ار او الاي اف ار فور ذا ايبيكارديال، السي اف ار اللي هو الكرونري فلو ريزيرف، ده بيدينا فكره عن الابيكارديال اند مايكروفاسكولار، نوت اكسكلوسيفلي مايكروفاسكولار. في اندكس تاني برضه بيتقاس اوتوميتد باي ذا سيم واير اللي هو الاندكس اوف مايكرو سيركيولاتوري ريزيستنس، والكات اوف فاليو بتاعته 25. This is very important to diagnose exclusively microvascular disease.
And this is also mentioned in this consensus.
تمام.
There is a lot of slides actually, but this is the simplest one. But it was difficult, but this was the simplest one.
شكرا جزيلا.
Thank you very much, Professor Nabil. Wonderful presentation as usual. الحقيقة highly informative excellent. Patients بقى اللي عندهم myocardial bridge. Do we need to do provocation? We need to do invasive assessment in the cath lab for patients who have chest pain due to myocardial bridge, or those patients?
هو المايوكارديال بريدج is another يعني another entity يعني completely different from those with microvascular angina or vasospastic angina. المايوكارديال بريدج يعني انا هقول لك بس ان في البوست مورتم ستادي، لقوا ان 80% of the patient عندهم myocardial breach. Myocardial breach is not rare. Myocardial breach is very common وبيختلف من شخص لشخص. That's why the best treatment option for myocardial breach is medical treatment, mainly beta blocker, just to decrease in myocardial contractility. Intervention wise, surgical wise, is not recommended. Just a medical treatment for myocardial breach, because maybe 80% of all of the setting here have a myocardial breach. And this is a completely different entity from the microvascular dysfunction and coronary vasospasm.
الماجورتي هماش سيمتوماتيك اصلا.
Yes.
والبريتش بتاعته فيري بناين، يعني هو حتى مش محتاج ميديكال تريتمنت. يعني هو معظمهم اكسيدنتلي ديسكفرد او بيتصور بسببنا، فلو كان هتقدر تثبت ان ده عامل له اسكيميا وتقدر يعني هيبقى بيتا بلوكر او هتستخدم ميديكال، انما حتى معظمهم بيبقى اسيمتوماتيك واكسيدنتلي ديسكفرد.
Actually, I have small questions because I don't have the answer for Professor Dr. Magdi and for you, Professor Nabil. Dr. Magdi, in the morning we have questions about ischemia trial, and we found 20% of patients assigned for revascularization, and 1/5 of them, that means 20% of them had normal coronary. So are they Dr. Magdi told us in the morning, they have the processed in dedicated process to appreciate their ischemia, their coronaries, and everything. Are these 20% belong to INOCA, and what's happened for them? I don't know.
لو يعني I think in 20% most probably belongs to INOCA. But I would like to mention that in this guidance they mentioned that 70%, not 20%, 70% who did coronary angiography have INOCA. لو احنا خدنا كله على بعضه اللي هو عندهم كمان lesions، يعني خدنا كمان اللي هم عندهم stenosis 50%, 60%, 70%، دول included in the INOCA as long as in the FFR or IFR is not physiologically significant. They considered non-obstructive. Once in the FFR or IFR is not significant, they considered non-obstructive. فلو خدنا كل العيانين دول على بعض لقوا ان تقريبا 70% of the patient اللي هو doing coronary angiography are considered INOCA.
حابب اضيف برضو لحضرتك انه even after PCI وجدوا انه resting physiology بالاي اف ار لو برضو اقل من 0.95 this is indicative of an associated microvascular disease, residual pain، وده بنشوفه كتير. patient after PCI يظل complaining يقول لك انت ما عملتليش حاجه، انا ما استفدتش. We have to look to this entity and optimize the medical treatment زي ما حضرتك قلت according to this. شكرا جزيلا استاذنا دكتور نبيل. Very fruitful presentation. Thank you.